Thompson. I'm one of the anaesthetist and intensive care doctors, and this is really quick, okay? All I want to talk about is, this applies to you if you're going to work on the wards, so it's what to do if patients are getting worse, okay? So this is the history, so kind of back in the midst of time, then a few people noticed that before people get really sick, you can figure it out beforehand because all their kind of vital signs start to go a bit haywire. So initially we started to notice about before 2000, and then NC probably noticed it as well about 2005. So what we have now is we have a special system that hopefully helps you notice people when they get sick, so you do something about it. Okay. So what happens? So first of all, sick patients are recognised. So that's usually down to the nursing staff doing their national early warning scores. Okay, and then that flags up something, and then they have to do something about it. Okay. So that doing something about it is using, we've got a graded response system. It's similar to wherever you've worked before, okay, whereby according to how sick you are, you get increase in your frequency observations and you get a review by an appropriate person. Now, if they're, and then when you see those patients, then you're going to make a management plan and also contingency plans should they continue to get worse or your initial management plans don't work. So this is our vital signs observation chart. So this uses the National Early Warning Score. So recap, aggregate score for every vital sign. The more abnormal it is, the higher the number. Add them together and you get a big number. The bigger the number, the sicker you are. Okay. And then, depending on that number, the nursing staff will activate what happens next. So, this is our kind of grade response system. So if you've got a national early warning score between 1 and 4, so you're a bit peaky but not too bad, then the nurse is looking at the patient will tell the nurse in charge, okay, they'll increase the frequency of vital signs observations, they'll ask for a junior doctor, and they might ask for whoever's holding the 600 bleep. Now the 600 bleep is a baton bleep that goes between the critical care outreach service during the daytime, and there's a group of specialist nurses at night called the acute response team, and they hold it during the night time. So basically what you get is you get a double-pronged response. So you get a medical response, and you also get a response from some specialist nurses as well. So it acts as a safety net, so that hopefully we can actually try and sort out these patients. If they're yellow, so they've got a national early warning score of 5 or more, then they should get a much earlier bedside review by somebody a bit more senior, okay? And they'll also get seen by whoever's carrying 600 bleep, okay? And then if they're really sick and they're red, then they need somebody, they need a middle grade or above pretty quickly, okay? One of the reasons we have the 600 bleep is often, you know, sometimes for circumstances out of control, like might be a surgeon fit or doing something else, then there might not be somebody available to come quickly. So in those circumstances, it's all right to go up the ladder, okay? So if you can't get the middle grade, you can go up to get the consultant, okay? And that's it. And then what we need, when we see them, this is what we need. This is just basic good patient care. So you basically need to make a good plan for what we're going to do about these patients. So they need to decide what investigations you need, what interventions you want to perform. Importantly, if you're going to review them, you need to say when you want me to give you a call. So if they don't get better, then the vital signs are still abnormal within 2 hours. Give them another ring, something like that. So you tell the nurses what to do next. You might need to talk to somebody a bit more senior. You might need to ask for somebody for a different specialty. And then it would also be nice to have a contingency plan, because not all the plans are going to work. So what's going to happen if they continue to get worse? So are they somebody who actually they'll be approached for critical care, or maybe they should have a ceiling of care, such as continue kind of basic management on the ward, or actually is the fact that they're getting worse that sign they're dying and need to be on the end of life path. pathway and not be frustration. That's it really. That's me finished.